So hello again. I'm Remo165 to a lot of you guys. Please call. As hard as it is to be disrupted during the workflow, it's important, and you guys do a lot of medicine, and you let us reach out and do medicine with you. Disclosures, sometimes when I tell my wife I'm charting late at night, I'm actually on my kicker bike doing bike workouts. That's why I'm a little sweaty during this presentation. I have no financial disclosures. I'm a resident. This lecture, it features some branded products, especially regarding chest tubes, needle decompressions. Albany Medical Center doesn't endorse these products. I don't endorse these products. It's just a good way to provide resources to show you guys how I recommend going about doing these procedures, so that we can have a conversation about it. And if at any time you see something that I mentioned that you disagree with, or you could shed some light on, or something you've actually done in the field, I would love for someone other than me to talk for the next hour. And I'll keep an eye on the chat as well. So the aim, I got this Jones and Bartlett learning series that I understand was once used pretty widely in the pre-hospital medical world, with a focus on chest trauma and abdominal trauma. I was given guidance to focus on penetrating chest trauma and penetrating abdominal trauma, and I'll do my best to highlight key principles, concepts, and trauma there. And we're going to learn together. I'm not perfect. I will try and provide references. I have references at the end. So yeah, we'll talk about common causes. We'll talk about what it means to be hit in the box. We'll review life-threatening complications of gunshot wounds and other penetrating trauma, and we'll formulate a shared language. Yeah. Why listen to me? I didn't ever really do EMS work, but I was a medical officer, Fleet Marine Forces. I was a naval medical officer. We cover the Marine Corps infantry because every one of them is a rifleman and a warfighter. The only academics that they really push that are not pure infantry are their lawyers, which still have that killer instinct, but their chaplains, religious services, and medical personnel are Navy. So I did a lot of field coverage. I never went to combat, but I did see my share of a couple of GSWs as well as some C4 injuries and accidents, and I did a lot of training with my corpsmen. These pictures are from training exercises we did using pigs, as well as simulations. And I developed ATLS training and tactical combat casualty care resources, as well as writing the exam for Fleet Marine Forces. So I'm by no means an expert. I'm a lifelong learner, but I reviewed your treatment protocols, as well as my own resources, and as well as the guidance for what we should be teaching. So I always include these slides. I don't have anything to say about them, except that it seems to me this is a pretty limited amount of guidance for someone who has to be first on the scene with a penetrating trauma, which is that you maintain airway, breathing, circulation, get vital signs, give airway support with oxygen as necessary, cover a sucking chest wound with an occlusive dressing, and release momentarily during exhalation and get the person to the hospital quickly. And then for more advanced care, it's still fairly limited in its guidance compared to what it is that you guys provide as far as support for an acutely decompensating patient in the field. Please, if you have a patient who is really sick, as soon as you're able to, get us on the phone and we can problem solve together. But the immediate life-threatening injuries, which we'll cover, a lot of them you need to take action before you can get us on the phone. And so if you're going to memorize a medication, if you're going to memorize a treatment protocol, if you're going to get something rote and just drill it back and forth, it should be these. So let's build from anatomy, and then we'll jump into some case-based anatomy, and then I'll talk about some of these traumatic injuries that we should review. From an anterior viewpoint, you can always use a midline, the manubrium, and ribs as well as the clavicle to give us description. It matters a lot to us if you're talking about a penetrating trauma if it involves the neck or the chest or the abdomen. And you can use these as hard lines. Anteriorly, you can use the clavicle, you can use the medial clavicle, the lateral clavicle, and a midclavicular line in order to give us an understanding. You can also use the manubrium and the xiphoid process. And if you tell me that there's a stabbing and it's midline and it's inferior to the xiphoid process, I have a great visual image and a lot of confidence in the report that we're getting. And it allows us to prepare the right things so that when the trauma arrives, we have the right resuscitation tools, supplies, and personnel bedside. Similarly, on the posterior, you can use bony anatomy. If you palpate the scapula, if you tell me it's a stab wound and it feels like on exam, it is medial to the angle of the clavicle or the medial aspect of the clavicle, that tells me where it is. And it can also tell me vector and what structures underneath might be hit, okay? So the diaphragm is a very important structure to discuss regarding penetrating trauma, and it covers a wide range. Think of it as the billows, the big muscle that helps inflate and deflate the lungs, and understand that it is a dome shape. It tapers inferiorly as it travels posteriorly, and it allows for important structures to pass through. If you take away the function of the diaphragm, either with trauma to the spinal cord or trauma to the diaphragm itself, it takes away the ability to drive air, and that necessitates you providing ventilatory support. We'll get into that a little bit later, but for someone who has a legitimate diaphragmatic injury, whether it's a penetrating trauma or a acceleration deceleration injury causing a diaphragmatic hernia, being able to drive positive pressure either through a bag valve mask or through CPAP, or more importantly BiPAP, that's going to overcome the patient's inability to ventilate. And as scary as it is for somebody for you to do their breathing while they're awake, it might be what is necessary to augment their breathing to keep them stable while you get them to the hospital. The diaphragm can be as high as the cupula, which is where the lungs themselves sit. But in an anatomically normal person, you should consider anything from T4 to T10 to T12 as an area where you could compromise the diaphragm. And you could potentially be hitting a structure that's above the diaphragm. Ribs 8 through 10 still attached directly to the sternum. And for most people, ribs 11 and 12 are floating, so you'll be able to palpate their tips laterally. Yeah, big takeaway is appreciate how high the diaphragm goes and how much of a travel it has on an inflated lung. So if someone gets hit with a gunshot wound with a full breath, you can have a diaphragmatic injury that strikes the lungs all the way down. Let me show you posteriorly. Actually, sorry, I'll cover the lateral surface anatomy first. And this is important as well when we're talking about needle decompression, and we're talking about chest tubes. Think of the front of the chest as well as the side of the body with 3 major lines to delineate where an injury is. I have here a dotted line showing you the anterior axillary line. So looking at the axilla, putting a midline, and then putting on either side of the midline equidistant 2 more lines, you'll get the anterior axillary line, you'll get the mid-axillary line, and you'll get the posterior axillary line. And then similarly, anteriorly, you'll have this mid-clavicular line, as well as you can see on the diagram here, a midline that goes through the umbilicus and through the xiphoid process. This is another helpful surface anatomy image that shows you the inferior angle of the scapula and the scapular furrow. Some people will use muscles on a really muscular patient. They'll talk about the rhomboids in order to help you appreciate that furrow. But I would just stick to the median furrow of the spine, or you can talk about the medial limit of the scapula as where an injury is. And then this is what I was referencing earlier, an area which seems pretty extreme, but it can be the traverse, the path of the diaphragm on inhalation and exhalation, T4 down to T10, pretty commonly discussed as an area where you can have direct diaphragmatic injury. So some case-based anatomy, and then we'll jump into some cases that we've seen at Albany Med. This is a really helpful CT scan with labeled anatomy. When you're seeing a CT scan, especially when you're seeing it with these slices, the patient is always laying on a table with their feet facing towards you. And in this series of images, we're starting superiorly near their shoulders. You can actually see the scapula here in yellow, and then we're going to move inferiorly towards the toes, and you'll see more structures come into play. So you can see the aorta here, the bigger circle being the ascending, and then it arches around and then drops back down. The blue structure that's splitting here would be the pulmonary trunk, bringing blood flow to the lungs on either side. You can see the sternum anteriorly, as well as some pec muscle up on the top, and then you can see all of those nice ropey back muscles that the patient is laying on here. So now we move down a little bit, and this picture helps explain why the right ventricle is the most commonly injured structure in the heart with penetrating and blunt trauma due to its location anterior and close to, but not often touching, the anterior chest wall. It allows it to have a lot of impact with deceleration injuries, as well as any stab injury. A large surface on the front is going to be the right ventricle. So now jumping into a case that we saw some of you might have been involved in. This was a 16-year-old kid that came in with a GSW to the right chest wall. And he presented panicked, shocky, with a wide pulse pressure and disproportionate dyspnea. He had decreased breath sounds on the right side, and he seemed to be doing okay after we gave him some oxygen support and some fentanyl, which helps calm most patients. And then 5 minutes later, as we're trying to keep him flat and bring him through the CT scan, he starts to panic. We're not able to keep him down in the CT scan. His blood pressure starts dropping precipitously. His pulse pressure drops. He becomes hypotensive, shocky, and we have to use push dose pressors to keep him alive through the CT scan. We end up pulling him from the CT scan and doing some subsequent ultrasounds, and I'll highlight some of the findings here. We actually did get the CT scan here. So we brought the patient in. He was unstable. He had a needle decompression done in the field that was successful, but didn't result in a whoosh of air, but didn't produce blood either, and did produce some amount of air. And the patient seemed to improve afterwards. Any patient that gets a needle decompression in the field, once they come into us, if they weren't hit in the chest before, we now have needle that goes into the chest, causing entry wound to the chest. So we then follow up with a chest tube. So things to point out on this scan: again, the patient's laying on the table, their feet are facing towards us, and we're moving often from the head to the toe when we review images. You can see the heart. You can appreciate that the right ventricle is the most superficial structure on the heart, or sorry, the most anterior and the one that would be hit first when shot from the front. And you can see the lung cavities. The area that's pure black within the right chest cavity is air. The area that is below that has a flat, straight line, and these straight, flat lines really should never occur in nature, or at least in the human body. This would be the layering of fluid, so that would make a lot of this here blood. And then this ring here, if you want to think and guess on what that is, I'll come back to it. And then really important on this image, this band and the indicated 11.7 millimeter fluid here around the heart. This is fluid around the heart called a pericardial effusion. And in this case, especially with trauma, you have to assume this is blood. So again, this is the pneumothorax, or air in the chest wall. This is the pericardial effusion. And this is the chest tube that we placed in order to drain the blood. It was putting out a significant amount of blood, so the patient went directly to the OR. Here is a chest x-ray of the same patient with the same findings. You can see we saw them in A2. It shows an area on the x-ray where you can see the absence of something important. You don't see any lung markings in this area, up on the superior aspect of the chest wall on the right side, and that's a pneumothorax. So that's where there's air, and it's allowed the lung to come down from the chest, the edges or the where it normally sticks along the pleura of the chest cavity, and allows it to fall down. And you can see the lung markings are more dense in that lung that's fallen down on this chest x-ray. You can also appreciate the heart border here, and that shows that this is the left side where the heart sits. And more importantly, it shows, and this is something that you'll pick up on the more chest x-rays you look at, but it's not a normal appearing chest x-ray from a cardiac perspective. You kind of lose the definition along the heart, and that also hints at a injury to the heart. And then most importantly, when we first saw this patient, we saw a very lateral right-sided chest GSW. And then when we got the x-ray, we saw that the bullet had traveled. So what's the read on this one? You have a pneumothorax. That's based on the CT read. Radiology was not convinced based on the x-ray alone, simply because of the blood that was layering. Let's see, in this hemothorax. And then you can also appreciate that this is a bullet. And when you have a bullet that's entered on the right side and appears to be crossing into the left side, and this patient had no exit wound, you have to be concerned about a involvement of the heart. So contextualizing specific injuries, I want to spend a little bit more time talking on blunt force penetrating trauma, GSWs, open chest wounds, impaled objects, hemothoraces, pneumothoraces, and the various flavors of pneumothoraces, as well as some other specific cases that we'll get into if time allows. I'll make sure to leave time for Elif. Keep advancing. Okay, time for a public service announcement. Your presentation when you arrive with a trauma patient especially is our primary source of data for these injuries. It's important for you guys to be as busybody as possible. I'm empowering you to ask all those questions that are horribly uncomfortable to ask, but you show up and someone may have been stabbed by their domestic partner, and as uncomfortable as it may be, provided you are in a safe environment, ask, hey, can I see the weapon? Especially if you have multiple vehicles responding, and often these traumas, you'll have a chief's vehicle or someone else show up. See if you can get a photo of the weapon so that you can see length and shape. See if you can get the information on how many times the patient thinks they were stabbed, as long as they're able to still talk to you, because they may not be talking to us. As well, ask the assailant or other witnesses what they saw, exactly the events that happened. And yeah, as much information as you can get, maybe even collecting phone numbers. It's all incredibly helpful for us. And then one more request is, if you don't have another call that you have to get out to, stick around a bit and help us out. If you want to get hands-on, we're always so grateful to have extra help and extra hands. And even if there's a flurry and there's lots of people in the room and you have an unstable trauma, sticking around to find out what happens in the case and to give any additional context can be incredibly helpful. Sometimes I'll ask a paramedic when they bring in a patient, or an EMT, hey, can you stick around? Hey, can you not leave yet? And I understand if you say, no, we got places to go, but if you can stick around or at least leave some information to help us, it's important. So blunt versus penetrating. When you have blunt injury, consider solid organs, because they translate the impact a lot more directly, and that's your spleen and liver. Those are the commonly injured organs with blunt trauma. Consider compression and crush injuries as well, because they can't be squished quite so easily, as well as any shearing injury, because solid organs that are anchored on a stalk, like, for example, the heart, which has a thick myocardium, and even the aorta, think of it as a solid organ, because even though it's fluid filled, it's a denser structure than the surrounding tissue. It's at risk for rapid acceleration and deceleration injuries. Penetrating trauma, you can get injury to anything that falls within the line. So if you're shot through and through, any organ that could fall in the middle could be injured. In addition, if you have a high force injury or a high velocity injury, you have to be concerned with cavitation, which will cause injury to surrounding tissue, and I'll talk a little bit about later. you also have to be concerned for like a shotgun injury, especially in close range, carries an incredible amount of force and can translate injury throughout the body. So some features of GSW. When you have a gunshot wound, you can discuss the caliber. That's the diameter of the bore. It's usually expressed in hundredths of an inch or in millimeters. For example, he was shot with a 9mm. That would be 9mm in diameter projectile, right? The magazine or clip, that's how many of those individual rounds you have to load into the weapon. So if someone was hit on a drive-by and they say, oh, the car drove by pretty quickly, and then they recover it, and you see that there's 6 rounds or 8 rounds in the magazine or clip, unless someone's reloading because they've got a real vendetta, you know how many injuries you may be suspecting and how many bullets you should be recovering. And I realized that in a catchment like Albany Med has, with a huge rural area, most of you know more about weapons than I do as a guy who was a medical officer in the military. They didn't often trust us with weapons. Magnum is something you can infer, but that's exactly what you'd expect. It's the load. So it can be either the amount of mass or the size, like in a shotgun, the amount of payload, or it's the amount of powder in a round. When you have laceration or crushing, that's normally from a low speed projectile, and define that as less than 1,000 feet per second. Whereas if you have cavitation injuries, which I'll show you as a picture to help explain later, that's when you have a very high speed. It actually distorts and displaces surrounding tissue, causing an outsized amount of injury. And you might have injury to tissue that's not directly hit by the vector of the trajectory. Hollow point, this is when a bullet has a defect at the very tip, or a hollow tip, hollow point, and that simply allows the round to distort, open, causing more wounding potential. In shotgun considerations, when someone's shot at close range, it can do a significant amount of damage. When they're shot with a shotgun from a wider range, you have to explore kind of the whole entire body that could be affected based on the surface that was facing. And then entry and exit wounds. You can almost never definitively say one wound is an entry wound and one wound is an exit wound unless you have an awake patient who shot themselves and is giving you a story, or you have like unquestioned video evidence showing the injury. There are a couple of exceptions, and I'll show one soon. So this shows a couple of different rounds that you may run into here. A 9mm. Yeah. Sorry, I didn't realize I had muted. What is going on?
Sorry,
Art, can you confirm you hear me?
I was moving the screen over. I think I muted you.
Oh, okay. So I was going to say I'm throwing a lot of words out, but I don't think I'm ready to get hooked and muted. So, but I'll try and keep moving. This is the concept of cavitation. When you have a round traveling at a really high speed, it translates force outwards, creating a cavity as it moves. Think about it like as the air or tissue displacement, or like the effect of a torpedo or a very high traveling submarine as it travels through the water. Yeah. This is a guy who came into Albany Med, really frustrating case. Just a couple of weeks ago, he was out hunting. He was holding a rifle, and you can guess what happened. This is one of those cases where you can say this is the entry wound because you can see, you can fill in here, but there is a muzzle burn, and that's what you get when you have a firearm that goes off really close to the surface of the skin. So he caught himself in the leg. Fortunately, he missed the femur, and he was discharged that day with close follow-up with orthopedics after a really thorough washout and being started on antibiotics. Here are 2 more pictures, and this shows you the exit wound. But again, if you had a patient that was shot more than a few feet away and you showed me this in the absence of giving me the full story and having the patient report, you can't say if this is the entry wound or the exit wound. This is another case from November of 2023 of a man stabbed in the chest, and we're going to talk a little bit about open chest wounds. The biggest thing is to realize that if you have a large open chest wound, air is going to preferentially travel in through that hole because it's a much easier path, and air is lazy. It's going to travel in the area of least resistance. It's a lot easier for air to go into a big open hole directly into the chest cavity than to travel up through your nose or mouth, around your fat tongue, down through your airway and your larynx, and then splitting in the bronchi and eventually going out to where it's headed as it gets into narrower and narrower passages. So you have to close that, or the air is only going to travel in that direction. In addition, rather than expanding lungs as compliant as they are, they still have some tension and integrity to them. So air is going to preferentially fill into an area where lung is not. So a pneumothorax is going to continue to grow, and the air is going to continue to leave the lungs. So the way you fix that is you put on an occlusive dressing, and whatever you have available, even a latex glove or a nitrile glove stuck on there simply to cover a bubbling wound, provided you make sure there's not something to poke you, is the right move. And then from there, getting a more permanent occlusive dressing on there. And if you do feel the patient's acutely decompensating while you're working on getting ready to decompress the chest, letting the patient letting air out on exhalation can temporize, right? Because the same way that the air is going to be happier to jump in the hole on an inhalation, it's going to pass out preferentially from that open chest wound hole when you expire. So signs and symptoms of a chest wound: dyspnea, bubbling and gurgling, an obvious impaling injury that shows that it's involving the chest wall, hyperresonance. But again, if you're tapping on somebody's chest after they've been stabbed or shot and they have a bubbling wound on their chest, I think you're getting lost in the weeds. Do what you guys are trained to do, which is identify a problem and render immediate remedial action, right? So cover it up. Maintain airway, breathing, and circulation, provide oxygen, because most patients, they're going to be somewhat limited in their ventilation, and they may build up their carbon dioxide and they may get a little bit loopy, but they're going to die if they're not getting oxygen. So deliver oxygen in whatever method you have available. If you are a EMT and you're the first on the scene and the tools you have allow you to provide airway, breathing, and circulation, oxygen's the way to go. And if you have a major diaphragmatic injury, again, even bagging an awake patient might be the right move. Call REMO for support, reach out to ALS units en route, and do what you can to get the patient to us. If you can get a patient, even a significant penetrating chest trauma, to one of our trauma bays, these patients have great results. So yeah, this is a picture. It shows a Schenectady Fire working with Mohawk Ambulance Service. They brought a patient into Albany Med. This is from 2023, and I don't know the exact injury of that. This was a fun one. This is a GSW, and the question is this a chest wound or an abdominal wound? And the fact is, you can't tell, and at that level, I'd say you're almost definitely involving the diaphragm and hitting structures that are both above and below the diaphragm. The important thing is to still throw on a occlusive dressing. If a patient is shot on the shoulder, on the upper aspect of the shoulder, and you throw an occlusive dressing on there, in my opinion, you're right, not wrong. If a patient's shot and it looks like they're shot in the leg, but it's not clear that this is within a muscle in the leg, if there's any doubt about a wound involving the chest or the abdomen, I want you to assume that it is. I've activated plenty of traumas for patients that get stabbed by pocket knives or shot by BB guns, and they get hit in musculature in the leg or in the hip or in the buttocks. And it's not the wrong move. It's better, honestly, to have a robust response and then peel back the same way most of the EMS services do pre-hospital, than to have a very serious injury show up and not have the right resources. Let's see. So this is what we were just talking about. So for impaled objects, an impaled object or foreign body should not be removed in the field unless the patient cannot be brought into the hospital. And even then, I would consider that an extraction. And before you work to extract the patient, I would talk to REMO and make sure that you have a really strong plan and the resources you need in the field before removing that patient, provided the patient is stable. It's important to see the size, shape, and trajectory. That's one more reason to keep an impaled object in the patient. And it is reassuring that a quarter of all abdominal stab wounds do not penetrate the peritoneum, so they don't hit internal organs like viscera, but the flip of that is 3/4 do. Some pearls from the Atlas of Emergency Medicine regarding penetrating wounds or stab wounds. They cause injury to structures in the past or in the path. For that reason, we use FAST, which is our ultrasound approach, in order to better visualize these injuries. When patients are stable, we'll take them in for CT. If they're unstable and they have a penetrating wound that we believe involves the chest or the abdomen, these are patients that go straight to the operating room. I think this is really silly. This thing's called an impal. And again, they're not paying me. They might pay me not to talk about it, but it's such a rare event to come in with a patient who's impaled that to carry something like this, that's a very purpose-built thing that'll only hold some impaled objects in place. It just doesn't make a lot of sense. EMS and emergency medicine, we are the improvisational kings and queens of our trades. And I've seen some really impressive things done by fire and EMS in order to maintain an impaled object. This is really cool, this picture here. This is a patient who took a structure from the windshield of an antique vehicle into the axilla. And rather than buttressing the impaled object itself, they used resources they had in order to keep the arm up and out of the way of the axilla, so that in transport, the arm wasn't knocking this object in order to protect the underlying structures. And they used some gauze or maybe a t-shirt as well around that wound in order to get hemostasis. Where's Leibowitz? So I apologize for my somewhat unprofessional discussion there that's caught on the audio of this ultrasound. But let me just play that again. This is an ultrasound of the right upper quadrant of a trauma that we had come in. So on an ultrasound, the signal is going from the top. This curve shows us that we're using a curvilinear probe, and it's showing us as you go down into the tissue, what's happening underneath the skin. So there's a white or a bright line that's a curve there, and that's the chest wall. And then that little thing that you see flickering that keeps waving back and forth like seaweed in the ocean is actually the tip of the lung. And all of this black that it's swimming in is a large hemothorax. So it's a lot of blood that lung is sitting in. It's displacing the lung. Air doesn't transmit the sound waves, so an ultrasound shouldn't show you much in the chest wall. It shouldn't be able to show you the lung flapping around like that. The fact that it's showing you the lung shows you that there's blood in the chest wall there. And that was a case pretty clear for us placing a chest tube. This patient actually didn't get needle decompressed in the field and was hemodynamically stable enough to be talked through and given analgesia and local numbing and a talking or a counseling and coaching before we place the chest tube. So blood, again, accumulates in the pleura, in the area between the chest wall and the lung. As it fills, it compresses and displaces the lungs. Pre-hospital management is ventilatory, is supportive care, it's oxygen, but give us a call early if you have a patient who's requiring increased oxygen support and has penetrating trauma to the chest, right? That this patient may benefit from a specialized intubation and specialized positioning where we might put the affected lung down and may benefit from positive pressure, and then obviously from draining that bleed. Things that'll tell you you may have a hemothorax if you have dullness on percussion, which I don't imagine you're going to be doing. If you have tracheal deviation, it could be from the hemothorax. You may also get hemoptysis, which is where the patient will be coughing up some of that blood because they have injury to the lung parenchyma, or the main tissue of the lung itself, in addition to the blood that's pooling in the chest cavity. Supportive care, rapid transport, oxygen, and get IV access because this is a patient that will need blood. Next thing to discuss briefly is flail chest. It is rarely relevant in immediate resuscitation. Most patients, because they have an injury to some small amount of ribs, will be able to still drive with their diaphragm to bring in and out air. But you can imagine if you're taking a big, deep breath in and you're relying on this rigid structure that's the chest cavity to hold the lungs open, if you have this flail segment, which is disrupted and can move separately or paradoxically, as you take a big breath in, that flail segment will go inwards and it'll disrupt your ability to breathe. These are patients that benefit from positive pressure. So if you are a unit that has CPAP or BiPAP or can somehow get that in and on to the patient, by giving them ventilatory support, you can make them do a lot better. If you are out there and all you have is a BVM, that can still be valuable. You'll talk the patient through what you're doing, and as you see them gasping for air or gulping like a guppy, when they take a breath in, you can support or augment their breath. That's something that if it's not in your protocols, I'd be talking to Remo about, but it's certainly something you can do to support these patients. So I'm going to go on a bit of a deep dive on needle decompression because there's been a lot of discussion in the literature and in some EMS groups, and I've seen it done at least once in a patient that came into Albany Med, about taking an alternative approach to the anterior chest wall. So first, this is a pneumothorax. It shows a tension pneumothorax. It shows a collapsed lung with a functional one-way valve, or air that's getting in and now not coming out from an injury on the chest wall. When that happens, it displaces the trachea. It puts pressure on the blood flow, that is blood return to the heart, and can put someone into a shock state very quickly. For these patients with a tension pneumothorax, it is life-threatening. The appropriate treatment is a needle decompression, and I would encourage you, if you have this concern, or you have an unstable patient, or you have a traumatic arrest, they should not die without bilateral needle decompressions, and they should not die in our trauma bay without bilateral chest tubes. Okay, so here is where the discussion gets pretty heated. So Rebel EM did a great summary of this primary source, which is a very thorough review of the optimal anatomic location for needle decompression. You guys should all be able to rattle this off, and you do these more than we do. We're much more likely to place a chest tube, and with an 11 blade and a finger, we can get access to the chest cavity pretty quickly. However, in the field, you should be doing one of these two locations, and my argument to you that's well supported by the literature is that you should be going midclavicular. So here is a diagram showing the ribs and showing the navel, or the nerve, vein, artery, and lymphatic tissue. In this case, the vein, artery, and nerve that course along with a rib, the intercostal vein, intercostal artery, and intercostal nerve. They're on the inferior aspect of a rib by design, because whether you believe in intelligent design or pressure of evolution or some combination of both, it is very smart to put these structures protected and hidden underneath bone. So when you're placing a needle for a needle decompression, you should palpate. You should find the second intercostal space, midclavicular line, and you should identify that rib. And then I would encourage you to travel in a vector that's going directly into the center of the patient's body with your needle. You should tap the rib and then alter your trajectory either by shifting the tissue in your hand or slightly adjusting your angle to the point where you slide just above the rib, and you'll advance until you feel yourself enter through the pleura. And for most patients, this is approximately 3 centimeters. The alternative location would be going anterior axillary line, 4th to 5th intercostal space. And for large muscular patients or super obese individuals, there were some in emergency medicine that believed the better approach was taking that anterior axillary line. But we found now in studies of cadavers of BMIs of all sizes, specifically BMIs over 30, that as a patient gains weight or has a higher BMI, that anterior axillary line actually has a thicker layer of fat on average than the anterior chest wall. And it even is the same for very muscular individuals as well. So I'm going to take you through the approach sorry. So first, pneumothoraces, again, establishing the terminology. A closed pneumothorax is where you have an injury that violates the chest cavity that allows the lung to collapse but doesn't allow air in and out. An open pneumothorax is the one you see bubbling or you hear kind of whistling in and out and is open. And those are the ones you're slapping on an occlusive dressing and then attempting to burp during expiration. And then a tension pneumothorax is one where the air is able to preferentially run in during inhalation and can't escape during exhalation, causing a significant decrease in venous return and putting a patient into a shock state pretty quickly. And those are the patients that show up with the distended jugular veins, kind of a purple appearing face, they're gasping for air and they're decompensating quickly. Again, I have no endorsement of North American Rescue, but I built my personal carry med bag from their equipment, and they make a pretty great, well, no, I'm not saying that. Yeah, they make a pretty great educational PowerPoint, and so that's why I've used their slides, and it takes you through step by step. So identify the sternal notch, identify the sternoclavicular space, identify the acromioclavicular ligament. So now you know exactly where the clavicle is. You can put your fingers so that they span from one to the other. You can find the midline. I like to do exactly what they're doing right here. First digit, third digit, and then use your second digit right there to identify where you want to hit the chest. Identify the middle of the clavicle, go below the clavicle, and identify the second intercostal space. You should feel first rib kind of right at that clavicle. As you move down, the next structure you're going to feel is the second rib. And then when you go just below that, you'll be in the second intercostal space, okay? So what you'll then do is you'll say, okay, this is the third rib. I want to make sure I'm at least above the third rib. And I'd encourage you to then find that second intercostal space, sneak just above that third rib in order to place your needle. So here it talks about marking and cleansing your area. If you have your hand on the patient, you've identified the proper structure and you have someone else to help you, I would try and clean the area, but you should be able to then place your needle. And again, all of these patients are going to be on empiric antibiotics. All these patients are trauma patients. They already have an invasion to their chest cavity. I'm not worried that you're going to give the patient an infection. We'll manage exposure later. The important thing is to fix the tension pneumothorax. So this is a helpful slide here. It shows the angle. It is a slight lateral to medial angle that you're taking in and trying to stay pretty midline. When we look at chest decompression, when it fails, it's because an individual is normally more lateral than they should be, and they're not taking a medial approach out of fear of hitting a vital structure. And what they'll end up doing is staying within the subcutaneous tissue and never entering the chest cavity. This shows what I was talking about earlier, striking the rib and then sneaking just above the rib. So you're going to go, you'll tap bone, and then you'll pass superior to the bone, and then you'll take a straight vector in. And here it talks about fingertip for depth control. I always choke up on any procedure, try and grab. Don't worry about getting the shaft dirty. Put your finger right on where the needle is entering the chest cavity and use that in order to direct your angle and keep yourself from sliding in too deep. Don't bury it. Place it approximately 3 centimeters out and then stabilize it. So this is kind of proprietary stuff for their device. If all you have is a 14 gauge IV, that might be what you use. All right. Successful placement. You'll ideally get a bubbling or a rush of air and an improvement in patient vital signs. But continue to monitor the patient. If the patient is showing improved vital signs, I consider that a success and make sure you protect this, okay? If you don't see any of those changes and the patient's still decompensating, I encourage you to try. Additionally, in the same approach, you could try moving approximately 1 centimeter to either direction. You could reassess your vector. If you're not successful that second time, if you're talking to Remo or someone with more experience, they may recommend then trying that anterior axillary line. So here's the anterior axillary approach, and again, it should not be your first approach. You should go anterior. Anterior at the midclavicular. But if you're going laterally, you'll go anterior axillary. Mark your area or feel it with your fingers. Appreciate that the safe zone is higher up, and breast tissue and sagging obese skin may throw off your location. Don't rely on the nipple or even like any kind of mammary crease to guide where you're going to place your needle for needle decompression. Find the anterior axillary line and get way up in that armpit. And then again, take approach that leads you towards the center of the chest cavity. And again, they're using first and third digit to identify the space they want to be, and then the second digit to verify exactly where their interspace is. Then you'll tap the bone of the rib, and you'll slide just superior to it in order to enter the chest cavity, okay? And this is reviewing the same information that was given from the anterior approach. Some of this is proprietary to them. Successful thoracic decompression. You have improvement of the respiratory distress, release of air from the catheter potentially, improvement of oxygen saturation, or return of pulses in a patient that's decompensating due to tension. Yeah, I got pretty into the weeds there. I encourage you to look into Aziz and all of the research done on your approach to needle decompression. Absolutely keep in mind that an anterior axillary line approach in the 4th to 5th intercostal space is an effective means and a good backup if you do not have success in the anterior approach, but your first needle should go anterior. Some other things to discuss, and I'll rely on Art or Dr. Uzan, sorry, to cut me off when my time is up. But some other key injuries that can be caused by penetrating trauma to the chest and abdomen. So cardiac tamponade is an interesting physiologic condition. Think of it like a boa constrictor. It's constricting the heart, and it's not so much keeping the heart from beating or contracting as it is keeping it from going into diastole, relaxing and refilling for the next pulse of blood, because the blood is filling that fibrous bag, the pericardium that holds the heart, so the heart can't refill. If the heart can't refill, then the heart can't keep blood moving forward by pumping it. It just ends up getting squeezed, right, like it's in a boa constrictor. When we talk about pericardial tamponade, we talk about Beck's triad. Beck's triad is hypotension with jugular venous distension and muffled heart sounds. There's also an ECG triad, and the most common ECG finding is going to be sinus tachycardia. You may also see electrical alternans. Seeing electrical alternans does not mean that the patient has pericardial tamponade, but it is an indication the patient has a pericardial effusion or fluid that the heart may be swinging on its anchor in. And because as it's swinging, the vector changes, the amplitude of the QRS changes. So you'll get this kind of high-low variation in your EKG. On ultrasound, there's also a triad, the POCUS triad, or point of care ultrasound triad, and that is finding pericardial fluid with a right ventricle diastolic collapse. And again, the right ventricle is that most anterior structure in the chest when you're dealing with penetrating trauma, as well as a dilated inferior vena cava. And that makes sense, right? If the inferior vena cava is the big vein that's like the elevator waiting line for blood to get into the heart, it's going to be plethoric. It's going to be really thick and full of blood because the blood can't get into the heart and then get pumped out through the body because the heart is not refilling. So it's not an issue of the heart's squeeze, it's an issue of the heart's refill. So back to that case of the guy that was shot in the chest and we saw the pneumothorax and the hemothorax, his initial ultrasound did not show a large pericardial effusion. But here you can see the heart beating, and I've seen more hearts beating than other people involved in this discussion because you guys are providing care pre-hospital. But I think you will appreciate that that heart is squeezing well, but it looks like it's being kept from refilling. And then here it is in a longer axis view, I think this is technically subxiphoid or looking from below, but you can see the heart, and it looks like the heart just can't take a big deep breath in. It can't refill in order to squeeze. And I've labeled the pericardial fluid there. So that patient earlier that had the large hemothorax, pneumothorax, that bullet did cross the midline and it hit him in the right ventricle, and he had an open wound in the right ventricle. So when he went for his emergent laparotomy and thoracotomy, and they cracked his chest and they looked inside, they took a minimal invasive or a minimally invasive thoracotomy approach. They were able to kind of pry him open and look in and repair a large hole in his right ventricle. And he was discharged 3 days later and then lost to follow-up because he didn't feel like coming to trauma clinic after he was fixed. It does not take much blood in the pericardium to cause tamponade. And the more fluid you have in a patient already, if they have a pericardial effusion or fluid around the heart, the less likely it is for them to develop tamponade. If they have a tight, thick, fibrous wrap around their heart, like a young person who doesn't have a history of a pericardial effusion would, it can be 50 cc's. It can be, less than a shot glass of fluid, and that'll take a patient from normal walkie-talkie into shock, obstructive shock. So what will happen is these patients will be fine, and then these symptoms will show up very rapidly: dyspnea, chest pain, abdominal pain, syncope, palpitations, and you'll see a narrowing pulse pressure and then severe hypotension and shock. And this shows that intrapericardial pressure. The patients compensate until, especially in this acute scenario, they don't, and then they fall off. Next thing to discuss is commotio cordis, and this is a relatively rare phenomenon that I think was probably not part of our common language until this guy, Damar Hamlin. I don't watch a lot of football, but this was big news. He was hit in the chest, and based on the timing in which he was hit, he went into cardiac arrest, and then pre-hospital personnel got his heart beating again, and that's why he's able to take this photo here. So you guys can mark that in your win category. But what happens is a patient gets struck right when their heart is in a vulnerable electrical position. And so it basically, someone raised their hand. That's cool. All right, what do I do if someone raises their hand?
I'm looking. I can let them ask the question, but
Oh.
Do you see who it is?
He said disregard. Okay.
Okay.
So yeah, a patient gets struck in the chest, and you get what's called R on T phenomenon. So when they're in their T wave, which is their repolarization phase, when the heart electrical activity is recovering, if you will, for the next impulse, they get another wham, which gives them this QRS, which is that nice impulse. If you've ever heard someone giving like a precordial thump where they don't have pads nearby, so they just slam some guy in the chest to give him maybe 50 joules of whoomph, you get that right on the T, and it puts him right into VTAC or asystole, because it basically puts a negative on a positive, and you get these patients either in VFib or straight into asystole. This shows other mechanisms: getting hit with a fist or a baseball or a lacrosse ball or a hockey stick. It takes something pretty focused that makes enough of an impact on the chest wall in order to hit the myocardium in order to cause a depolarization. And it's a relatively low survival thing because you need advanced care. You need someone trained to administer CPR and an electrical impulse in order to get these patients back. And probably the reason Damar Hamlin had such an excellent recovery is because he was playing in an NFL game and all of those personnel were right there. I'm sure he had pads on him within 5 minutes. Things that are less likely to be survivable: a traumatic aortic disruption. So this is a case, 22-year-old kid was in a high-speed MVA, passenger seat, was wearing a seatbelt, had this big deceleration injury, and chest pain with difficulty breathing. When this is a traumatic injury from a penetrating trauma, these patients don't often make it into our ED. But when they have a swinging injury, sometimes you see on a CT angiogram injury to the aorta, and then our vascular surgeons or our thoracic surgeons will go in and stent this in order to protect them. The biggest thing is to provide what care you can in airway, breathing, and circulation, and realize that these patients, they don't survive these, and it's not a failure of EMS. It's not something I can fix in our trauma bay. It's something that requires a very specialized surgeon. And I see that warning. These are two more common injuries. The first is a diaphragmatic injury. You can see the chest x-ray and where the lung should be, and then you see an area where you have an opacification or white that's blocking out that lung, and that's because this patient had either a penetrating trauma or a deceleration injury that let the abdominal contents enter the chest cavity. And again, these patients now have a not working diaphragm. Their bellows don't work. So they need positive pressure. They need to be ventilated. They need a bag valve mask to help them when they're trying to take a breath in, or they need BiPAP in order to keep breathing. The next picture is a pulmonary contusion. And you can see think of these as just bruising to lung tissue, the same way you can bruise external tissue. A bruise in your leg is probably not going to kill you, but if you bruise your lungs pretty badly, it's hard to exchange oxygen and carbon dioxide. Here is a CT scan of that injury, showing the abdominal contents entering the chest cavity. And similarly, here is this is actually not the same patient, but it's a similar injury. And it shows these blossoming bruises inside the lung tissue. And I'm sure it's causing the patient to require a lot of oxygen and probably to be intubated and ventilated in the ED. This is another catastrophic injury, a tracheobronchial disruption. These patients will have the Rice Krispies of air in the soft tissue in their neck and maybe in their anterior chest. Requires a very high mechanism or a penetrating trauma that hits the conductive airways. And again, these patients, the best thing you can do is to support their airway. And if you can see a pathway to intubate, these are patients that you'll often be encouraged to intubate, because if you're not intubating, the air will build up in the subcutaneous tissue and pinch off the ability to move air. So yeah, that's subcutaneous air. And then this is an ET tube carrying air in. This is traumatic asphyxia. When you have someone who's crushed or stuck under pressure for a long time, or maybe being choked out, or maybe a failed hanging or strangulation, or someone who's pressed in a riot, you'll see these findings. Big things to look for: upper extremity cyanosis, the conjunctival hemorrhage. They have these red, bloody looking eyes, face and neck edema, and an engorged tongue. It's really scary looking. You may see some purpura and petechiae like you see in this child, but provided they make it to your care and you can alleviate the pressure and you can get them back to appropriate airway, breathing, and circulation and provide ventilatory support, they do really well. So it's terrifying. They look like walking dead, but these patients will do well if you can get them out from their entrapment. Children especially, because they're so malleable, they'll get squished, but they won't necessarily break bones. And I rushed through that last bit because I wanted to get you guys to all my slides. But if you have any questions or comments, feel free to email me at landauz@amc.edu or drop by and say hi. Again, I'm Remo165. I'm super grateful for my time that I got to spend with you guys riding along. And here is a list of my work consulted. If you want the presentation, I'm sure Art can provide it to you. Rebel EM and Wiki EM are great. These are what I use on shift in order to teach our newer residents and our medical students for some just-in-time teaching. And if you see a case and you see us provide some additional care or next steps in the emergency department to do some learning on your own, I highly encourage you to check out Wiki EM. It's a great crowdsourced resource. And this is just some pictures of my time out with my guys. It's been long enough that I actually missed that experience. I don't want to do it again, but I do miss it, and it's a beautiful life. I'm super grateful for my time here at Albany Med and for the hour I got to spend with you guys just now. Please reach out. Thank you.
Thanks, Zach. That was great. Does anybody have any questions for Dr. Landau? You can put it in the chat or in the Q&A.
What are your thoughts? Yeah, I see this. What are your thoughts on using the MARCH acronym for trauma patients? Also, it's my understanding that 14 gauge needles provided by Albany Med for use for decompress are self-tamponading, so we'll need to break the seal by connecting a syringe. So for the first part, I'm really passionate about that. I think that the concept of airway breathing and circulation, it doesn't matter if you have an airway or you're ventilating, if you have bled out. There are things that kill you faster than lacking oxygen. And that's pretty obvious when you see us do an RSI. When we're intubating or when you're intubating, if you can bag a patient up, they'll hold their oxygen sat for minutes. So absolutely, hemorrhage is the first thing you should be covering, them, that mass hemorrhage. I think it's a great acronym. I don't know what the teaching is in our area, but absolutely, if you have someone who's just spurting blood, you've got to get that bleeding under control first. Please don't go against your protocols because they're what protect you from a medical legal perspective. But if you see me shot, I hope you put on a tourniquet and I hope you stop the bleeding before other things. Regarding using a 14 gauge and needing to throw on a valve, if any EMS